This is Connor Meadows going over the Pea-asystole cardiac arrest algorithm for paramedic protocol. So if you arrive on scene and the scene is safe and you find your patient and you determine the patient's airway, breathing, and circulation, and you realize the patient's in cardiac arrest, and you hook them up to the monitor, and you realize that the patient's in PEA or asystole, then you're going to immediately start CPR. You're going to perform high quality CPR, which is 100 to 120 chest compressions per minute, establishing an airway and providing oxygen to keep the patient's oxygen saturation at above 94% or at least 94%. You're going to monitor the patient, the victim's heart rate, and if possible, the patient's blood pressure. If you determine the patient is in asystole or PEA, then you realize that this is not a shockable rhythm. So at that point, you're going to be focusing on the things you can control, which is getting an IV, maintaining the patient's airway, getting the patient intubated as soon as possible. So once you determine it's PEA, not a shockable rhythm, you're going to continue the high-quality CPR for 2 minutes while your coworkers are getting the IV established and getting the patient intubated. Once that patient has an IV access or IO access, you're going to be giving the patient 1 milligram of epinephrine for the duration of the code, as long as the patient remains pulseless. And you're going to be giving that patient 1 milligram of epinephrine every 3 to 5 minutes. After the 2 minutes of CPR is up, you're going to do a rhythm check. If the patient at that time has gone into VTAC or VFib, you're going to move to the different algorithm. Unfortunately, if the patient does not convert out of the rhythm after the 2 or 3 minutes of CPR, then you're going to not only continue CPR and continue giving epinephrine, but you're also going to start thinking, if you haven't already, you're going to start thinking about the H's and T's. What are some other possible reasons why this patient, depending on what their age and physical appearance would be, as to why this is happening and why is this patient in cardiac arrest. If the patient were to return to the get a ROSC return after this care is provided for you, then you're also going to be moving to a different algorithm. And if you do get ROSC back, you are going to actually continue for another 2 minutes of CPR because you're priming the patient's pump. But again, that's ideally the goal. And unfortunately, if you don't get ROSC back, depending on what your protocols are, you're generally speaking going to be transporting the patient to the hospital while continuing to provide this algorithm of care until the ER staff takes over for the patient. But in summary, for the Pea-asystole cardiac arrest protocols for paramedics, you gotta make sure you have all of your equipment in place, batteries packed, batteries charged, medications organized, ready to go, and you gotta make sure that you know the big difference is always going to be in cardiac arrest. It ultimately comes down to, does the patient have a shockable rhythm? If the patient doesn't have a shockable rhythm, that means they're in PA or systole, and CPR and epinephrine is really going to be the main things that you're going to be able to do for the patient. That's pretty much it.